Hi, so let's begin this lecture with a case. And uh, so, a patient of around 40 years, he presents with sudden lower limb sensation loss, okay, and motor. He cannot stand. Also, that there is increased BP. The weakness in the lower limb is gradually increasing, and by gradually I mean less than in less than 4 weeks. All right, that is within 4 weeks. So I'll write and within 4 weeks. Okay, and it progresses to the upper limb, and there is loss of reflex and also arrhythmia is seen. Fair enough. What would be in your differential diagnosis? All right, so first thing is that you need to figure out that there is an ascending pattern. Okay, so the lower limb is involved before the upper limb. All right, second is that you need to figure out that there's a element pathology, because obviously there is loss of reflex. Third is that it's acute, it's within 4 weeks. All right, and very important clue that it gives is that there are certain ANS manifestations, because there's increased BP and there is arrhythmia. So there are a certain amount of ANS manifestations. Now, when you think of all of these loss of muscle tone and bilateral involvement, all right, you definitely think of a very important disease called as Guillain-Barre syndrome. You can keep CIDP also in your mind. That's chronic inflammatory demyelinating polyneuropathy. But obviously, I think CIDP would be more chronic, obviously, than obviously our Guillain-Barre syndrome that we're looking at. So that's why you need to figure out that if it's a CIDP or if it's a Guillain-Barre. All right. So far we are thinking in terms of Guillain-Barre because it's ascending, it's LMN, it's acute. And usually this is kind of a case presentation that we have. So let's directly get into Guillain-Barre syndrome. What is the scene with Guillain-Barre? The scene is that it's an autoimmune condition, and autoimmune condition actually leads to antibodies that are attacking the myelin. Okay, so they are attacking the myelin. Any other condition that you can think of that attacks the myelin is multiple sclerosis as well. But that is actually the one that's attacking the oligodendrocytes. But here we are looking at the Schwann. Okay, so you got to keep that in mind as well. Second is that, is it associated with any particular infection? Well, you need to keep in mind that Campylobacter jejuni is very important, and viruses like EBV, Zika. You want to keep these two viruses in your mind. Okay. But definitely Campylobacter jejuni is something very, very important that can come as a case presentation to you as well. Now, when we say GBS as the Guillain-Barre syndrome, it has different varieties of it. One is your AIDP, one is your axonal motor or AMAN, second is your AMSAN, third is the MF. So AIDP is basically the most common one, and it's actually nothing. I'm just trying to cover the basics out here. That's why I'm giving up the types. Otherwise, it's not that necessary. But AIDP is acute inflammatory demyelinating polyneuropathy. So it's acute, it's inflammatory, it's demyelinating, as we've already said, and it's a polyneuropathy. Similarly, as I've already said, that there is a chronic demyelinating polyneuropathy as well. Very similar. Okay, so that is AIDP. It is with anti-GM1 antibody in case. And then we have the AMAN, that's the acute motor axonal neuropathy. Then we have the acute motor and sensory. Okay, this is just motor neuropathy. And then we have the Miller-Fisher syndrome. Okay, it's not that very important, but just for the sake of covering everything, this is also your anti-GD1 antibody. Okay. And this is your anti-GQ antibody. Okay. So GQ, GD1, GM1. All right. Second point that I wanted to get into is that how does it present? Well, as you've seen, that there is first lower limb tingling, then numbness. Okay, so there's like a sensory loss. All right. Then there's also motor loss, obviously motor loss. Okay, and is it, what kind of a motor loss is it? Is it like the proximal or distal muscle? Well, it's both proximal and distal. Okay, then it finally progresses to the upper limb. All right, and definitely it can also lead to facial paralysis. Okay, can lead the face, and it can lead to respiratory failure as well. Definitely autonomic manifestation are seen in the form of BP fluctuations, arrhythmias. All right, and bladder symptoms, bowel and bladder. Now in bladder, I wouldn't say a neurogenic bladder, but I could say that urinary, I wouldn't say stress incontinence. I cannot even say overfilling. I can say overfilling incontinence, definitely. So bowel and bladder symptoms can be seen. There are no higher mental, so higher mental function is preserved. Higher mental is preserved. Okay, so there is nothing like loss of memory or any of those issues. Sensory can be affected, yes, and obviously CSF protein is positive. There is increased protein in the CSF. So yes, that is how a typical case of GBS will present. You want to do your diagnosis. You do your diagnosis by nerve conduction study. You do a nerve conduction study and you can see a conduction block. Okay, why you can see a conduction block? Any guesses? Obviously because of myelin damage. As I said, anti-GB1 or anti-GM1 antibody greater than anti-GB1, greater than anti-GQ1 antibody. All of these are affecting the myelin, so obviously you'll have a conduction block, and that's pretty basic. Second, I can do an LP, and on LP I'll see CSF proteins. All right, I'm tired of saying this. Increased CSF protein. Is there any other place where we've seen increased CSF protein? Definitely in multiple sclerosis as well. In multiple sclerosis, we saw increased CSF proteins. With increased CSF proteins, are you going to see any leukocytosis? No leukocytosis. No leukocytosis. Okay. How do you treat this condition? Well, let's say you've diagnosed everything. You want to treat the condition, obviously. So any particular treatment? Note. If someone's saying steroids, obviously not. Straight go for no. Now the reason being that we've seen that steroids doesn't work, and we think Guillain-Barre is an autoimmune, so steroids is gonna work. There is no role for steroids. So what do? We do IVIG. All right. Or you can do a plasmapheresis. And that is about it when you talk about Guillain-Barre syndrome. Next, just to complete the topic of such similar diseases, I really wanted to get into a very important disease, that is CIDP. All right. Just like acute inflammatory demyelinating, just like AIDP that we had of GBS out here in the classification, AIDP, acute inflammatory demyelinating polyneuropathy, we have something called as a chronic inflammatory demyelinating polyneuropathy. Is that a part of GBS? Not a part of GBS. Not at all. Why is it chronic? Because it's more than 8 weeks. That is 2 months. Let's say it was between 4 to 8 weeks, it would be subacute. Is this necessary? Not at all, just general. Is it steroid responsive? Yes, it's steroid responsive. So that is why I'm saying it's different from GPS. It is not GPS because GPS was steroid unresponsive. Is there any cause like Campylobacter jejuni? No. Is there any ANS involvement? No. Is there any bulbar involvement? Rare bulbar involvement. What do I mean by bulbar involvement? Bulbar involvement is basically cranial nerve involvement, the bulbs. All right. Any secondary causes for CIDP? Well, you could say HIV, Hodgkin's, SLE, etc. What is the pattern of or the clinical features? All right. What are the clinical features? Well, the clinical features are motor plus sensory minus ANS, no ANS. Well, I am saying ANS, I'm stressing on ANS because I want to make sure that you can differentiate it between from GBS, sorry. Okay. It is an LMN. Yes, it is an LMN because there is areflexia. Okay. Large fibers are affected, so there's loss of vibration. Okay. And obviously there's loss of muscle tone, muscle tone. It is flaccid, etc. Just like an element. How do you want to treat this? As I said, it's steroid responsive. Do you want to do IVIG? Why? If it's steroid responsive, no need of IVIG, but obviously you could do that. And if not, then you could do PLEX, that is plasmapheresis. Okay. That is another inflammatory motor neuron disease that we've covered now. In the next lecture, probably we will look at Charcot-Marie tip disease. So thank you very much.